যে হোয়াটএভার আপনি সাজেস্ট করেন এটাই তো কি অনেকে
Dear moderator, you can start your talk.
আসসালামু আলাইকুম চৌধুরী হাফিজ ভাই।
স্যার ওয়াদুদ স্যার আমরা কি শুরু করব?
Yes.
এই এখন কত দাঁড়াও
শুরু করে দাও ভাই।
ওকে ওকে
আতা ভাই শুরু করে দিক।
না ঠিক আছে।
ওকে আসসালামু আলাইকুম and good afternoon prospective physicians. Today we have 48 sessions.
তোমার সাউন্ড কম।
Assalamu alaikum and good afternoon, respected physicians. Welcome you all in today's session. This is 48th session of ECG study group, which is case studies on ECG. Today we have two distinguished persons among us. First, Dr. Abdullah Al Jamil, and from Nepal, Professor Arun Maskey. Before starting the program, I request Professor Abdul Chowdhury sir to introduce these two dignitaries among us. Wadud sir.
Assalamu alaikum and good evening, everybody. Welcome again to our regular ECG discussion. I would say ECG Adda. That's the better term, I should say. And today we're going to have talks from Professor Arun Maskey from Nepal, my friend, and also from Professor Abdullah Al Jamil. Let's talk about a little bit about Professor Jamil Bhai. Jamil Bhai is an electrophysiologist, a clinical cardiologist, also an interventional cardiologist. He loves actually teaching, but unfortunately, as he's not regularly associated with any medical college or postgraduate institution, we are actually losing the benefit from such a, I should say, acclaimed teacher. This is the forum where we can actually see how Dr. Jamil can actually manifest his qualities in teaching. Not everybody can become a teacher. He's one of those persons. The second is Professor Arun Maskey. Maskey is not only a professor of cardiology in his native country, but also a very good organizer. And that's a very difficult task to do. With limited resources, if you can put together a very beautiful program of teaching, that's really a hard thing to do. And Professor Arun Maskey is doing that regularly. I have gone there and have been an examiner in their MT exam and found out his passion. He's not very expressive, but in his heart, the burning desire of teaching is so much there. I really adore him. Ladies and gentlemen, let's have let's enjoy the presentation from these two distinguished teachers, Dr. Abdullah Al Jamil, Dr. Arun Maskey. Thank you. জামিল ভাই আপনি আগে শুরু করবেন?
হ্যাঁ জামিল
শুরু করছে। Can you see my slides?
Aziz Bhai is here today.
No, share your screen, Jamil.
I have shared it. Is it visible?
Not yet.
Just change the slides. Yes.
Is it okay?
Slides. So
Yes, we are seeing it.
Okay.
Thank you.
Good evening. Assalamu alaikum. Today I'm going to present two ECGs first, then two cases. This ECG number 1. Ribu, please give poll.
Okay, sir, for how long? 30 seconds or 20 seconds?
20 seconds.
20 seconds. Okay, sir. Starting the poll then.
Okay. Sorry. What would be the diagnosis in this ECG?
জান ভাই আপনি ডায়াগনোসিস গুলা মুখেও বলেন, ওরা শুনতে থাকুক আর এদিকে দেখে দেখে।
Options are atrial fibrillation with normal ventricular response, sinus arrhythmia, ventricular pre-excitation, normal sinus rhythm.
We have already have the poll
Yeah.
and it's a distributed response.
Yes. So, anyone want to explain it?
Yes, I can, if I permitted. Sir.
Yes.
yes, Govindabal.
Yes, sir. Yes, sir. 12 lead ECG shows sinus rhythm and short PR interval in visible in lead 2 and also V5, V6, and also now lead 2, V5, V6 is more well visualized, but other lead not. In that case, we can say intermittent pre-excitation. Intermittent pre-excitation.
Can it be manifested
We have to see
excitation
delta wave.
without intermittent? Why
Yes, sir.
intermittent, Govinda?
Yes, sir.
Why intermittent?
As because all PR interval seems not to be short, and delta wave only visible in lead to V5, V6, but others not well visualized. Lead to V5, V6 are delta short PR interval and also delta wave sliding. For that reason,
Can it
intermittent
be in
pre-excitation.
a manifested pre-excitation? Can it be in some leads not visible, in some leads is more visible?
Can I make a comment?
Sure, sir.
Yes, sir.
If you look at the distribution of the answers, 8 people answered atrial fibrillation,
Sir.
6 sinus arrhythmia, 10 ventricular pre-excitation, and I think it was 0 normal sinus rhythm, or very few. So we have to explain why it is not atrial fibrillation, if it is not.
First, should I explain, sir, or anybody else?
Yes,
would?
please. Yes,
Okay.
you, please do. Yes.
First, all the it's almost regular in rhythm. The RR interval are regular, and all the QRS complexes are preceded by few waves. So it's not atrial fibrillation. In lead V4, V5, it seems to be some undulation of the baseline, and maybe it's due to U wave and P wave. Otherwise, there is no other cause to say it's the atrial fibrillation. In atrial fibrillation, usually it is irregular. There will be undulation of the baseline, and this undulation might be technical error during the recording of the ECG paper. And so I think it's not atrial fibrillation.
Okay, so I buy that. I mean, it's fantastic. One of the things that for the young audience who is there, that there is no irregularity. That's important. Even though there are some waves which looks like a fib, having regularity takes that out. Then why is it not sinus arrhythmia?
In sinus arrhythmia also there will be some irregularity with phasic changes with respiration. In some there will be some slow rate followed by some little bit rapid rate with the change with the respiratory phase.
Okay, yeah. So please remember these things. I mean, we are, thank you. One of the things is that the people who did not think this is pre-excitation, because the PR interval actually is not short, it's 120 milliseconds. But as Jamil mentioned, that there is subtle pre-excitation, slurring in lead V4, V5, V6, 2, 3. So you have to keep that suspicion. Sometimes we can actually see this in a normal pattern also, but we have to suspect that. Okay, thank you.
Thank you, sir.
স্যার এখানে একটা পয়েন্ট বলতে পারি স্যার জামিল স্যার আপনি যেটা বলছেন স্যার যেটা মানে in WQW syndrome best observed lead হচ্ছে B5 and 6 is because the away from the far away from the AB node lead 5 and 6 most reliable lead to see 5 and 6. Sir, Rafique sir, do you agree with me, sir?
No, I disagree with you, Azam. It depends where the pathway is located. If it is located in the free wall or posterolateral, left posterolateral wall, then V5, V6 is more conspicuous, delta wave can be seen and shortening of the period more discernible. But if it is posteroseptal, inferior leads usually shows this delta wave. In right free wall also similar. And if it is mid-septal, then very difficult to separate from the normal conduction. So we are often have to pace from the his catheter to separate this thing, whether it is through pathway or from the through the avenue. So it's not fixed that always it will be discernible in the lead V5, V6.
So, sir, here two answer is correct actually. It's a normal sinus rhythm and also pre-excitation.
Yes.
Sir, I have a question to Jamil. I have a question to you and finally Rafique sir. Sir, if this question is set in the examination, whether 3 and 4 options is appropriate or not?
Well, I mean, the question is, in the question, I think what Jamil meant, normal sinus rhythm, normal ECG. That would have been a, if I am setting up this question, I'll say normal sinus rhythm with, and the number 3, I will put it as sinus rhythm with pre-excitation.
Yes, sir. Yes, sir.
So, but, yeah.
Let me, to answer Athar's question, the way the EKG question answer set up here is they give you a score, total score for a question. They want to know what is the atrial mechanism, what is the ventricular mechanism, what is the atrioventricular association, and then does it follow a specific pattern and a specific diagnosis. So in this question, if it is in the board, it will ventricular pre-excitation will carry the highest marks. For normal sinus rhythm, you may score 1. But if it is a total marks is 10, I'm just giving you an example, then 8 or 9 will be on ventricular pre-excitation, because that will carry the biggest weight.
So I'd like to make a small comment. I think even if it is, you can think that 3 or 4, I'd probably definitely go for 3. I'll particularly, let's focus on AVL lead, how the P wave, like delta wave, looks like. That is definitely delta wave. And if you compare that, Rohit Bhai can comment on that. And V5 we see slurring, we see the 2-3 AVF, and Dr. Jamil was correct, where the vector is coming from, what direction going. So you can see more excitation in that area. But AVL, the delta wave, is fairly prominent, so I would not say it's normal sinus rhythm. I'll say it's ventricular pre-excitation.
But Aziz Bhai, to interpret from the AVL is going to be a little difficult compared to in this EKG compared to B5, B6. I think it also tells, as Ajam pointed out, we need to look at all leads, and Jamil Bhai pointed out, depending on the accessory pathway, but we need to see all leads. My question to Jamil Bhai is, Jamil Bhai, what's next? Because EKG and beyond, what is next?
Next, if it is incidental finding, the patient should be assured. Sometimes patient comes with abnormal ECG, they are very much worried whether that they have got heart problem or not. So if the patient is asymptomatic, just reassure him, and except those persons who bear the responsibility of large number of people, like aircraft pilot, bus driver, this kind of people, they should, I think they might get ablated for this, as if he has antidromic tachycardia, then he might get unconscious while driving or flying. So that's an exceptional case, but usually if asymptomatic, no treatment.
Sir, I have another question to Rafique sir.
Yeah.
Hello, sir. Sir,
yes.
Sir, in this case, when there is a doubt whether there is any pre-excitation or not, sir, is there any non-invasive test like ETT? Can it help to unmask the pre-excitation? Is there any way to sure whether there is any pre-excitation or not, non-invasive way, sir?
Yeah. I mean, one of the things is that to get the rate faster, to see if we can see it better. I think in this ECG, we have to keep the suspicion of delta wave, but this ECG actually is not very definitive. I would like to see another ECG. I'm sure Jamil has another one.
Sir, pardon me, sir. One thing I like to know. Ventricular pre-excitation. Is there any term atrial pre-excitation? Actual term is pre-excitation or ventricular pre-excitation? Pardon me, sir.
Term is ventricular pre-excitation. I never came across with atrial pre-excitation.
No, we don't use it.
Thank you, sir. Thank you, sir.
Javan, I have a question.
Yeah.
Actually, without having the rhythm stiff, can we comment on sinus arrhythmia in this ECG?
আচ্ছা আমি একটু বলি জামিল ভাই, এটা আমাদের জুনিয়র স্টুডেন্টদের জন্য বলছি, আমরা উত্তরগুলো দেখি।
টাইমার যেহেতু দাওনি এখন আর দিও না।
Atrial fibrillation with normal ventricular response. এখন atrial fibrillation, if we consider atrial fibrillation, there should not be any P wave. All the QS complexes are P wave. So that question now answer is out. The second is sinus arrhythmia. If we are giving that answer, it should have a rhythm strip. We do not have a rhythm strip here. So that question should be out. You should not consider it. The third is ventricular pre-excitation. Why should it be there? Actually, there's a clue in there. For an exam purpose, if you are thinking about it, there must be something. Otherwise, this should not have been coming here. So I would look very carefully and I would find out the pre-excitation. Normal sinus rhythm, that answer is correct. But which one is more correct? The preventricular pre-excitation. And that's what Hafiz Bhai was saying. This will get more marks, that one will get a little bit less marks. But both the answers 3 and 4 are correct. But more correct is ventricular pre-excitation. That's the way when we come into exam, we should think logically to get out the best answer.
Thank you, sir.
Asad, probably you got your answer.
Yeah. Thank you.
Thank you.
So, Jamil bhai, I just wanted to emphasize few things. Asymptomatic alone is not good enough to be reassured. Maybe Rafique bhai, you can make comments. I think we need to take the thorough history, family history, and also physical exam, structural heart disease association.
Yes, sir.
We need to exclude. And then in case of occupation, we may need to do further in terms of arrhythmia detection. But I think I would definitely examine, see whether there is an association with Ebstein's or hypertrophic cardiomyopathy, and then get an echo. Rafique bhai?
Now, I said, Hafiz bhai, I said that if it's otherwise asymptomatic and no other comorbidities, then it should be reassured.
Yeah.
If Epstein, it should be taken care. If there is Epstein with atrial, interatrial septal defect or ventricular septal defect, that should be corrected.
Is there any pre-operative precaution if asymptomatic patient, is there any need to surgery, cholecystectomy like that? Is there any precaution or any drug treatment?
For pre-excitation patient? Yeah, that's a very, very important question. Rafique sir, would you please answer?
Well, I mean, we all do pre-op all the time. If this patient comes to me and needs the immediate urgent gallbladder surgery, I will tell the anesthetist that, look, there is a pre-excitation, no history of palpitation, keep an eye on it, have necessary resuscitation tools available if the patient goes into SVT or something, but go ahead with the surgery. Unless there is any other risk of coronary disease. Hafiz, do you agree with that?
Yeah, absolutely. I think the emergency, urgency, time-sensitive surgery is one thing versus an elective surgery is a different thing. And then you just, sometimes you need to compromise some anesthesiologist if the patient is elderly, coronary disease, and other valvular disease, or any structural heart problem, heart failure, they may want an echo, but don't delay the surgery.
Thank you. It's a very pertinent question. I think we need to keep bringing the operative part. I mean, it's interesting that very few people die from the surgery. They die from something else during the surgery.
Yes.
Unfortunately.
Should I go for next ECG, sir?
Yes, please, please.
Sir, can I ask one thing? Is any other thing visible in this ECG? There is prominent U wave.
U wave.
P3, 4, 5.
Yeah, I think what happens when you get pre-excitation, you distort those waves. Like it's like we do not know how much pre-excitation. It's like phased beat that you can distort the T waves. So it's difficult to comment on those in this kind of setting.
Rafique bhai, may I request you to comment few things that this patient comes back with palpitation and what kind of arrhythmias and what we should look for in the arrhythmia situation. This orthodromic, antidromic, and the drug use. I think it is pertinent to highlight that.
Sure. What I'm going to do, I have exactly same ECG on a patient. Once Jamil is finished, I'll take 2 minutes to show those ECGs.
Okay.
Thank you.
Okay. I go for the next ECG. This is what is the diagnosis? Atrial fibrillation with normal ventricular response, ventricular pre-excitation with sinus arrhythmia, ventricular pre-excitation with atrial fibrillation, short-run VT, SVT, sorry, short-run SVT. Whole Review poll, please.
Yes, sir. Starting, sir.
I'm going to be like in the election. Please vote. Vote according to whatever you wish.
Everyone should vote. Whether correct or
yeah, because when you vote, you have a commitment. Please vote.
Can we stop the background noise, please?
কারো ফ্যানের আওয়াজ আসছে।
Review even show the display the answer.
Sir, there is a technical issue. We have started the poll. Can we give 20 seconds more?
Sure.
জামিল, এটা কি তোমার ফ্যান নাকি?
না, আমারটা অফ করে দেখলাম, আমারটা থেকে না।
গোবিন্দ?
জি স্যার, আমারটা হতে পারে, আমি বন্ধ করছি ফ্যানটা।
তুমি মিউট করে রাখো, তাহলেই হবে। খালি কথা বলার সময় ওপেন করো। ঠিক আছে।
That's a good response. 43 persons answered, and 34 gave B, ventricular pre-excitation with sinus arrhythmia.
Amil bhai definitely is a good teacher.
Jamil, we still 5 people said atrial fibrillation. Let's do the AFib again.
Okay, sir. In this ECG, first atrial fibrillation, it as the every QRS complex is preceded by few waves, especially in the rhythm strip at the bottom, and also in all other leads except few, say AVL and the V2, P wave is not much discernible, but in all other leads, there is P wave preceding every QRS complex. So it's not atrial fibrillation.
But then why did they think it is AFib?
That is because the QRS complex is little irregular.
Exactly.
Initially slow, then it is fast, then again it becomes slow. So this irregularity is considered, they consider to have atrial fibrillation.
Yeah. So the point that Jamil, you are trying to make is, first of all, yes, there is an irregularity, but there is a pattern to it, right?
Yes, sir.
Exactly. So please, whoever answered, I'm glad that you did answer, but please look at those carefully. Yes, I'm glad that you noticed the irregularity, plus please notice the pattern, and more so the presence of the P wave. And that will take away AFib.
And in case of sinus arrhythmia, it is the whole PQRS changes, not the RR only. Whole
Yes.
PQRS changes. And Rafique bhai, আপনার ধৈর্য আছে, কিন্তু আমি আবার মাঝে মাঝে একটু বেফাস কমেন্ট করি। It is all about paying attention. আমি যারা pay attention করেন, আমি বলি যে if you don't pay attention, you may end up in dermatology.
Yes, but then again, Hafiz, my job is to teach.
Yeah, I know.
No, teach means, no, this is what I always say. even if you are an Air Force pilot, you may find it difficult to ride a bicycle, and we need to practice. And that's what we are going to do.
No, definitely. Kudos to you and Dr. Jamil bhai. Excellent.
Thank you. Thank you.
I'd like to make one point, Jamil bhai. Sorry, Jamil. যে অনেকে হয়তো POF-টা clearly দেখতে পায় না সব লিডে।
Asif bhai, there are Nepalese friends in here.
Oh, sorry. I'd like to make one comment that sometimes people are confused that some lead, as for example, like a couple of leads, the POFs are not very clear. But if you look at that, you have to look for in other leads what the POFs are best visualized. Like in inferior leads, V1, those are the leads you need to always look for. If you see any P wave, and then you know it is not atrial fibrillation. Okay. So that's first thing. And definitely irregularity can happen. You have to have in your differential what are the irregular rhythm could be. Whether it's just sinus arrhythmia, simple, whether there's any atrial flutter with variable conduction, or whether it's multifocal atrial tachycardia, and whether it's true atrial fibrillation. So if it's multifocal atrial tachycardia, then you'll see some variation of the P waves. It's morphology of the POFs itself and the PR interval itself, depending on what area, part of the atrium, the atrial focus is coming from. So if you, those four differential you need to keep in mind when you think about atrial fibrillation. But in atrial fibrillation, definitely you will not see P waves, clear P waves. So if you see any leads, P waves, then it's not atrial fibrillation. Most commonly you get consultation from primary care doctor that having sinus rhythm with some PSCs and computer reads atrial fibrillation. So you need to be careful. Look, if you see that frequent PSCs and EKG look like irregular, but if you see PUFs in those leads, definitely it's not atrial fibrillation. If always focus on the PUFs.
Can I make a comment, sir?
Yes.
When I was a FCPS second part examinee, I mistake the pre-excitation with old MI inferior. But in case of WPW pattern ECG type B, seems like old MI inferior. That means QAV in to 3 AVF. But in that case, if patient has had previous chest pain or history of MI, how can you differentiate the pre-excitation with old MI? Sir.
It is very difficult in that case to say whether the patient has old MI or not, especially in if it is left-sided pathway, there will be inferior QAs. If it is right-sided pathway, there will be interseptal QAs. So it's very difficult to say from ECG only. Rafique sir, please.
No, I mean, you're absolutely right. I mean, that's one point that it can clearly look like old inferior MI. We have to look at the PR interval and then, of course, clinical presentation of the patient.
But the traditional teaching is in the presence of pre-excitation, don't read any cues
MI.
as MI.
Yes.
Yeah.
So should I go for next?
Yes, please.
Hello, Jamil.
Sir.
Ajay, you please try to finish it 10 minutes, please.
Sure. So this is a case, 82 years old lady, hypertensive, non-diabetic, CKD stage 3 and with Parkinson's disease, presented with 3 days complaints of generalized weakness, loss of appetite, dizziness. On examination, pulse was 32 beats per minute, regular, and BP was, she was hypotensive, 80/40 at my OPD room, and altered level of consciousness. So this was the ECG I did, and what is the diagnosis? Severe sinus bradycardia, 2:1 AV block, junctional bradycardia, complete heart block.
Sir, the poll has been started.
Thank you.
Clarify your response.
First, it's
Janfai, the question I will be asking you, when you get a ECG like this, what is your approach to interpret the ECG? Then the youngsters can get some idea how they should prepare themselves.
it's a common teaching that I teach to my students. Also, I learned in the same way. Look at all the 4 leads. Look for rate. It's very slow, near about 30 beats per minute. And then I look for P waves. So there is no discernible P wave in any of the leads in front of any of the QRS complex. There is
okay, Jamil, can I interrupt you? I'm being the devil's advocate. I'm becoming Hafiz today.
Sir.
So if you look at lead 2 rhythm strip, I may argue that that small positive thing is a P wave followed by a tiny QRS complex. How do you say that's not a P wave?
It's very confusing in this ECG. And for to see this, I have to look at the other leads.
That's correct.
And in the same line, if we look above in the other leads, we can see that there is QRS complex in AVL especially, and in the pectoral leads. These are all the QRS complexes, not the P waves. These are in the same line. So it is QRS complex, not the P wave, and the tiny negative deflection. The explanation is probably it's a retrograde P wave conducting from the junctional tissue to the atrium.
And also could be below the node, because it looks like it's wider complex there.
Yeah.
Thank you. So I think what Jamil pointed out, if you look at lead V1, V2, V3, the line in front of the QRS complex exactly lines up what looks like the P wave. I think the whole thing in lead 2 is part of the QRS complex.
Yes, sir. Yes, sir.
There's a P wave sometimes retrograde in lead 2. So that's the whole point. So people who answered severe sinus bradycardia, I'm glad that you answered that, but it looked like P wave, but it is not P wave. Thank you, Jamil.
You're welcome, sir. And second is diagnosis is 2:1 AV block. So there is no discernible P wave, so it is not AV block. It's at the junction. So we cannot say whether it is 2:1 AV block. And C is junctional, as there is no P wave, only QRS complex. It may be from the junctional bradycardia. And lastly, complete heart block would also show some P waves in its own rate, and QRS complex is its own rate, and there will be definite AV dissociation. And if there is fusion bit or capture bit, then it confirms complete heart block. But in this ECG, no such criteria is visible. So it's a C is the correct answer. And I go for the biochemical analysis now.
Sir, any V1, QRS morphology of V1, V2, V3, the NOST, I think M pattern looks like V2, V3, and also V5, V6. Is there any comment?
It may be that it originating from the left bundle, the focus of the
Jamil.
Sir.
Dr. Jamil. Acha, Jamil, ECG please. Jamil and Rafique sir. Sir, in the lead 2, there is a rhythm strip. There is a slight distortion of the ST segment after the QRS complex. Regularly, this one, there is this slide. Can be the presence of the P wave?
Just before the T wave, right?
After QRS, before T wave, in between ST segment.
This may be the retrograde P wave.
Yeah, I agree with that. And it's not consistent, so there is a retrograde P wave.
Yes,
that's the most likely explanation. And the patient has baseline right bundle branch block.
Yes,
exactly, sir.
So I go for the next. After admission, her heart rate increased to 52 spontaneously. Blood pressure become much stabilized, 100 by 60 millimeter mercury. Patient still drowsy and disoriented. As there was hemodynamic improvement, TPM was not inserted. And this was the ECG.
So what intervention was done?
Okay. No, nothing. We just observed, and we just look for the biochemical. We're awaiting for the biochemical results. As the patient was hemodynamically stable, we didn't intervene anything, just supportive treatment. And this was the ECG.
জামিল ভাই পরেরটা দেখানোর আগে একটা কোশ্চেন যেটা আমাদের সবসময় আসে, জেনারেল কার্ডিওলজি এবং ইন্টারভেনশনাল কার্ডিওলজি যারাই অন কল এক্সেপ্ট ইপি, যে এই রোগীর যে দেখলাম আমরা টেম্পোরারি বিকেল 5টা বাড়ি যাওয়ার সময় হয়েছে, কিন্তু এটা কি টেম্পোরারি ওয়ার্ড দিয়ে যাব নাকি রোগী বেটার হয়েছে আমি এখন বাড়ি যাই? তো এটার ব্যাপারে sorry, I'll talk in English. So if you see this EKG and there is some hemodynamic improvement, do you see anything in this EKG that worries you that this is not a reliable rhythm and the night may not be a smooth night? Therefore, do you feel compelled to put a temporary wire now, or you just leave and then leave it to the on-call guy who will be really unhappy with you later?
And that's a very important question, Dr. Jamil.
Yes,
the reason being, the initial presentation, the patient came, he was hypotensive. So he was definitely hemodynamically unstable that time. That's the reason I asked about what intervention was done.
I admitted the patient immediately into the CCO and asked the mid-level specialists who are expert in putting TPM, and I told them to put a TPM. But when they found that the patient is stable, they rang me up. I was at the OPD. They said, sir, then I said, okay, wait. And after that, while awaiting for the biochemical report, we got this ECG. Rate improved. And now what is the diagnosis?
Serum electrolyte was normal, sir.
I'm coming later.
Oh, thank you.
I put the same answers here also. Just it is the similar ECG, but rate is little improved. And in this ECG, I'm not going for the poll for this ECG. At the bottom,
P-wave is better.
Retrograde P-waves are more discernible here.
Yeah.
More conspicuous, and QRS complex is more taller than the previous one in the rhythm strip, lead 2.
You're probably seeing a little bit more depolarization, and electrolytes may be getting better.
Yeah. Now this was the electrolytes on admission.
Yes. Potassium.
Potassium is high, sodium is low, chloride is also low. Carbon dioxide is also low. So the patient was a little bit stuporous and not responding to comments. And I shown this ECG as because in hyperkalemia there is usually a tall Q wave, but in this ECG Q waves are a little bit flat, rather not tall. Then this may be masking by the low sodium level also. This combined deficiency of electrolytes.
Sir, here lead to retrograde POF.
Yeah.
Sir.
These are the retrograde POF.
Retrograde POF. Yes, sir. Yes, sir. VA conduction.
Yeah.
Thank you, sir.
And this was the ECG on the next day morning. Electrolyte came down. Sodium was above 20. Potassium came below 5.5. And on the after full correction of the electrolyte, it discharged, and she has baseline Rachmaninoff plot.
I think our audience might have really questions that, you know, potassium was 6 point something, sodium was really on the low side. What's the approach is going to be a clinical approach to this patient? How you're going to correct it? Which one first? And I think you said the next day electrolytes are normal. Most likely potassium is okay, could correct it, but sodium I don't expect will be corrected. That's so soon.
No, we was not corrected so rapidly as because there is chance of pontine demyelinalysis.
Yeah, I just want to make sure.
Slowly.
Yeah, students
so again, it took about 24. More than 12 hours to it taken above 20 millimole per liter.
So Jamil bhai, the hyperkalemia giving junctional rhythm is well known, but hypernatremia or and potassium level has nothing to do with the mental changes. Mental alteration is all
was due to sodium. Yes.
Yeah, and then sodium has almost no effect on the EKG. Rafique bhai, you can correct me. That there is a hyper or hyponatremia, almost nil effect, unless there is an additional issue with acidosis, because that can give you ST changes. But this is all because of hyperkalemia. And I think there was acidosis also.
True. So I go for the second case. This is a 61 years old hypertensive diabetic, non-smoker, non-alcoholic gentleman presented with recurrent sustained VT with pulse and without loss of consciousness. He suffered angio-MI in 2000, followed by elective PCI to LAD. In 2015, underwent CAG again for effort angina that revealed triple vessel disease and underwent bypass graft surgery with 3 grafts. At that, after that, the ejection fraction was 35 to 40%, is moderate dysfunction. For recurrent VT, I implanted a single chamber MRI compatible ICD as the patient couldn't afford the dual chamber in 2017. He received ATP and appropriate DC shock several times during 4 years period and and terminated the VT. This time he presented with on and off palpitations since January 2021 and lastly presented in last month with palpitation for several days without receiving any shock. He was on sotalol and this was the ECG. Then what is the diagnosis? VT, SVT with aberrant conduction. Hold please.
By the way, if the patient comes in with this kind of white complex tachy and did not lose pulse and you don't know what to do, pray that patient loses consciousness so you can shock. So prayer sometimes works. That please pass out so I can shock you out. And then call Rafique bhai. I like Wadud term. This is ECG Agda. Like that.
Jamil bhai, would you please go back to the history?
Sure.
the one, yeah. A young audience, remember what Jamil Bhai said. He said because of the financial problem, they could not put a dual chamber ICD. Why he was saying dual chamber ICD? Single chamber ICD can do the work as well, but he was emphasizing that. Now look at the EF, 35 to 40%. If the patient in any way loses the AV concordance, he will lose the atrial kick. That's contributing around 25% of his cardiac output, 25, sometimes up to 30. And for that, to ensure in future, it would have been better if we can put a dual chamber ICD. But he was saying just simply a line, but it was not, it was in a very important context. That's why he was emphasizing that.
And I also like to make a comment, Dr. Jamil, that history is very important, because look at that, his history: extensive coronary artery disease. He had 3 grafts, he had an MI, he had a scar tissue. So scar tissue is always a thing about substrate for VT. So history will already tell you this. You see rapid tachycardia white complex, most likely VT, unless, sorry, I shouldn't answer the questions, they are already probably polling it, but unless proven otherwise. Just from the history, go further.
Okay. Paul, Vivo.
Sir, okay, sir, starting the poll.
I usually give a third option to confuse even more, that sinus stack with left bundle.
Yes, sir.
And then no read of STEMI. Inferior lead, people sometimes confuses this or call STEMI.
Jailpa, would you explain your answer?
First, it's white complex tachycardia, and rate is say around 130, 40 like that. And as with this scenario of the patient, I should consider this first as VT, as it's white complex tachycardia. I put SVT with aberrant conduction as because often we come across this kind of ECG with aberrant conduction with supraventricular tachycardia. So in this patient, I would consider VT for, from this scenario, but against VT is one in AVR. Usually there is a tall R wave, but here it's absent. But in favor, there is notching at the beginning of the QRS complex in the pectoral leads, say V3, V4. This goes in favor of VT. Professor?
Yeah, this is a fantastic ECG because few reasons. I mean, let's forget about the history of this. It looks like left bundle. If you look at the initial R wave, it is narrow,
yes,
which supports left bundle branch block. However, there is a notch in the QRS complex that supports VT. There is another criteria. In any chest lead, from the beginning of QRS complex to the deepest point of S wave, if there's more than 100 milliseconds, that's VT. If you look at lead V4, it's more than 100 milliseconds in lead V4. So it now fulfills 2 criteria of VT. The notch in the downstroke of the QRS complex and the duration from the beginning of the QRS complex to the deepest point of the S wave, especially measurable in lead V4, It's more than 100 milliseconds. So based on those 2 points, it's VT. Initially, I thought it was VT with aberration.
Is there any capture bit, sir? Already Chowdhury Hafiz sir mentioned sinus tachycardia with LVB pattern.
In this ECG, there is no capture of fusion.
In lead AVL looks like P wave.
But these are
Any
not
possibility?
These are not captured.
Thank you, sir.
And Rafique bhai, this is a one-to-one VA conduction?
It's tough to say. Even somebody who always make up stories, I can't really see much. I don't want to fall into your trap, Hafiz. I know you.
Jamil bhai, we have to be a little bit hurried because Arun Maskey.
I go for the next slide. Okay. This was the ECG after giving bolus amiodarone.
I'm starting the poll.
Review, make it 10 seconds, quick.
Okay, sir.
Jamil bhai, your response and explanation.
If we consider this ECG only, the answer, most of the participants answered correctly. There is left bundle block pattern and irregularity is there. It is irregularly irregular and there is no definite P wave. So it was atrial fibrillation after giving bolus amiodarone that terminated the VT, and this ECG came. I go for the next slide. This was on the next morning.
One question I have. This is the same patient that we saw earlier. You gave the amiodarone and converted to this.
Yeah, same patient.
Because I see the QRX complex a little bit didn't change much, rather widened.
Yes. This was the on the next day morning. The patient was stable and no symptom. And here there are some ectopic bits coming, and he has baseline left bundle branch morphology in the basic rhythm.
Very messed up heart.
Again, he presented with this type of another type of morphology of VT. I'm not going for poll to finish the slide. This is another morphology that is different from the previous one we saw. And the patient was having palpitation, and I could see the cannon waves in his neck. And again, we admitted and given the amiodarone, and it was terminated. And he left the hospital, and I put on regular amiodarone, but this caused trouble to his thyroid function. His PHS was much raised, so we have to stop the amiodarone. So lastly, 2 weeks back, he again presented with this type of tachycardia, this another morphology VT. And the patient was hemodynamically stable this time also, but he was having palpitation and was complaining he cannot lie down and feeling blocking sensation in the abdomen. And this time I did nothing. I interrogated, and interestingly, this was the ECG at the first time before putting the ICD. This was the pattern of VT he had. So it is another morphology VT. So these several kinds of VT in same patient denotes that it is scar VT, as he had entero-MI. So one patient have different kinds of VT due to array of electrical activity within this scar tissue. Have had several small circuit, and that initiates this kind of different morphology of VT.
I
And
have one question, Dr. Jamil. Was he evaluated for ischemia? Was he evaluated for ischemia?
Yes, that's the question.
for this time, I offered for angiogram, but he cannot afford to pay the bills for angiogram, and if needed any stenting or further revascularization.
And the EF dropped or EF same?
EF remains same between 35 to 40.
And did you have any ATP on the ICD, Rafique bhai?
Yeah, we have ATP. This time with this above this VT and also the previous two VT. With this VT we interrogated, and the machine was telling it is SVT, not VT. So it was not giving any ATP and shock. But last 4 years he's received several times ATP. If not terminated, received shock. But this
And
time,
I'd like to make a comment on that. Look at the V1 lead. The notch is on the right side. Okay, in the RV, right bundle branch block, you see the notch on the left side of the arm. So when it's white complex right bundle branch notch on the right side, definitely it's VT.
yes, sir. And in AVR, it is tall R wave.
My question to Rafique sir, when a patient comes with a several morphology of VT in a scar-related issue, what should be our approach to that patient?
I mean, the question is, somebody is having a relatively young person, we should consider ablation. Yes. Ablation will not cure the VT, but it will at least reduce the frequency of ventricular tachycardia.
Sir,
so that,
sir, if we also look for any, should say, ischemic substrate, should we not do that?
Yes. Ischemia does not, it should be done, but ischemia does not cause VT. Ischemia causes VF. So
probably not this kind of monomorphic VT you apply, because polymorphic VT ischemia can cause.
Exactly. Yes. So that's that's VF basically.
Yes.
Polymorphic VT. Yeah.
So may I ask any question, please, sir?
Rafique, please.
Yes. In first ECG, the pattern was LVV type, and here the pattern is RVV type.
Yes.
So whether the first ECG it is originated from the left because it is LVV type, so originated from right ventricle.
I will answer that question. Patient had an inferior MI.
No, sir. He had anterior MI.
Anterior MI, sir.
Anterior MI.
Yes.
So it depends on the scar location, how extensive the scar is. So even though we call left bundle, even if you look at inferior MI or anterior MI, it extended a little bit to the right side. And depending on the exit of the VT, the morphology will change. If it is exiting on the left side, it will become right bundle type. If it is exiting on the right side, it will become left bundle type. That's one. The other thing that happens with this ischemic VT is, if you look at the left bundle type, it is relatively narrow QRS. And that can also, sometimes they can get fascicular VT in some coronary disease patients. Thank you.
Thank you, sir.
Thank you, sir.
Jamil bhai, one important thing I wanted to highlight is the amiodarone-related thyroid issues.
Yes.
In your patient, it is hypothyroidism giving TSH high.
Yes.
But that is not an absolute contraindication to stop amiodarone.
It is correct.
Because in case of hyperthyroidism, and there are different types, then you think about this. So you can actually give amiodarone, and if needed, thyroxine supplement.
Okay. But yours progressively the TSH was rising in 2 successive sampling. It rise a lot. So I stopped it and went back to sotalol again.
Then
then
maybe another issue.
Okay, now, but support, referring to Hafiz's point, the forest has already been burned. When the forest was burning, the patient was hyperthyroid, and probably we did not see it at that time. Once the forest fire is done, you can actually use amiodarone, but I would prefer sotalol in relatively younger person to start with. Thank you.
Jamil.
Agree. Rafique, agree.
Jamil, please stop your screen share, please.
And
Abdul Wadud Chowdhury.
Arun Maskey, Jamil bhai, would you please stop sharing? Then Arun, we want to see the ECG from Arun.
I have to leave. Otherwise,
Very
I'm not
interesting
getting.
cases.
I'm leaving and coming again. It's not working.
Arun, are you here there?
Yeah, I am here.
Yes,
would you please start?
Okay. Okay, I have 4 short cases. I'm not going into poll. So that would be basically few educational and few interactive. So my first case is a 40-year-old male. He's a smoker. He complained of chest pain since one day with shortness of breath. Then he presented in emergency next day with sudden severe ischemic chest pain. He was dyspneic. His pulse was 120 per minute regular. BP was 80/40. Saturation was 84 after oxygen. It came to 94. Had bilateral basal crepe. So basically patient presenting with chest pain and acute heart failure. Hemoglobin was normal and ESR and everything was normal. Platelet was normal. Count was little high. BNP was 2500 high and D-dimer was negative. So this was the EKG of the patient. So there's a white space ST depressions, 2, 3 AVF and lateral lead. So with this history, so first thing would be ischemia. And this was the X-ray of the patient. So what we can see is bilateral fluffy shadows in both chests. So this is a COVID era. And this was a echo of the patients. What you can see is there's a regional ball motion abnormalities, which involves the LAD territory. There's no MR. And this is a echo at AR, which showed wall motion. So basically a patient presenting with chest pain, widespread STT changes in acute dyspnea with pulmonary edema. Did a CT scan in these patients. What you can see is widespread changes in both the lung fields. And this is another chest X-ray. So how should we proceed this patient? Is it ischemia? Is it COVID or something else? And
how bad is the hypoxia, acidosis?
Acidosis, we did not do AVG at ER. So saturation was 84. After giving oxygen, that has improved. And the blood pressure was around 80. So gave inotropic support and gave oxygen, morphine, and diuretics, slightly improved. So hemodynamic status has improved.
And in the COVID, is it like early COVID or late COVID?
We have a protocol because as soon as the patient comes, which is not very specific, we do some RT antigen. It was negative. And we do our protocol, which we in hospital, we don't do 24 hours PCR tests. We do early before 10. So this patient came in the afternoon. So
I'm just saying that how long is the illness? The time course of the illness?
No, 1 day.
Is it 2 days or?
No, 1 day.
10 days?
1
1
days
day.
of chest pain and
Yeah.
1 day of shortness of breath.
So this is all acute presentation. Acute lung, acute lung with COVID, and then heart failure, and then acute coronary syndrome presentation.
Yeah. Okay.
Can you go back to the ECG, please?
Yeah.
Hafiz, any comment on the AVR?
Yes.
Not only AVR, V1.
V1 also, V1 AVR.
V1 as well.
So it will be nerve-wracking not to go for cath in these patients, but often in COVID, and his platelets is 120. So we need, and we have no further platelet count. It may drop further. So it will be very important to think ahead that yes, we can go to the cath lab. We may find normal coronaries and stunning type scenario, or we may find multivessel and even a clot in the LID, who knows? But it is nerve-wracking. But I would argue that if any way you can buy time, I would buy time only because it is COVID. Otherwise, I would not wait. But my experience with COVID, little buying time, wait for blood gases, repeat platelets. For example, if the repeat platelets 12 hours later is 50, then you know this is going to go really south and you may not be able to do much. The D-dimer was high.
D-dimer was negative.
I think maybe too early because it's one day.
This patient has severe ongoing chest pain of 4 hours.
We have no choice.
You have to go to the cath lab.
You have to do cath.
Cath lab.
Dr. Maskey?
Yes, please.
But everybody will be saying cath, but I am the one, I'm very worried about this patient because the natural history of this kind of patients with the bad COVID in the lung, whatever we do heart is not going to be that good.
Can you give me information regarding total count, lymphocyte and
the
lymphocyte ratio? Because
14,000 was his count, high count.
Neutrophil and lymphocyte ratio is
no, I did not. Sorry, I don't have now. There was a neutrophilia around 80% was neutrophil.
The kidney is good. Kidney.
The kidney is good.
Okay.
So
now I just give you information. Neutrophil and lymphocyte ratio if more than 4 or 5, that gives you indirect clue it is a COVID. So, but despite your D-dimer negative, I mean, what was the CRP?
So emergency, we do not do CRP in all things.
Okay.
Neutrophil and lymphocyte, you are right. I have to check. I don't have that reports now.
This Azam, I think this chest involvement is not from heart failure. Looks like something more going on here.
Yeah, I agree with you. It most likely COVID, but if I get additional information from total count lymphocyte ratio, that will give you more confidence. But in that particular situation, we have to do something for this patient. What should we do? We should stabilize the patient by clinically as soon as possible by giving oxygen. He did it rightly, very nicely. And next issue is that whether we should go for cath lab or not. But this is the issue, whether actually in this high COVID era, whether we should go for. But if we see that there is a benefit come risk is more than one, then we should go for proceed to cath lab. Otherwise, we don't go for this. This is my approach.
Yeah, and we have done this, the thrombus extraction and no stent in this kind of patient also. So you never know until you go to the cath lab.
Yes.
Okay. So we took him to the cath lab. This is a picture. There was a left was high up, some degree of plaque in left main. Otherwise, not much of changes. Mid RCS is some plaque, but no changes. And this is another picture. So coronary is not significant. So maybe some degree of plaque in the left main. And this was a EKG next day. And I did a serial EKG on this patient. This was day 5th. This was in day 9. And interestingly, we did COVID test the next day. It was negative. And this patient's count increased to 20,000. We treated with antibiotics. And on 6th day, again did a COVID test that comes to be positive. And his saturation dropped. He was intubated, and after 2 days, he was extubated. And as the patient was COVID, we transferred that patient to general ward, general hospital. So I don't know whether this COVID
So
test
Dr. Maskey, I have a very important question to ask you.
Yes.
And this is something we are seeing compared to last year. Is this patient this year's COVID or last
this
year?
year's COVID, this couple of maybe 1 month.
Okay, excellent. Because that makes sense. Because in last year, we had a pattern of early COVID, viremia phase, then the immune thrombotic phase. But this year with the Delta variant, now in the US, particularly Las Vegas, we are going with the same problem again. our hospital is full everywhere. And we are seeing it is not following that pattern of viremic phase and immune thrombotic phase. Boom, day 2. Yesterday, one of my colleagues who was on call, he said, Chief, we should stop taking to the cath lab for unvaccinated patients because this is self-injury, because they did not take Delta variant, and Delta variant is doing this immune stimulation right from day 1. So this is very interesting. Your patient, and also we are having these issues, should we give them tocilizumab early on? It is nerve-wracking to give them tocilizumab in the early 3 days, but we wait, and if it is late, still LV bad, and the D-dimer comes in, I mean CRP and all that, and IL-6, we start giving them tocilizumab as well. But this is very important. That's why I told you, doing this for more than 1.5 years, if you did not take to the cath lab, I was still with you. But people, cardiology, whole cardiology and ICU will be upset with you if you don't take to the cath lab. But the LV function and the EKG and a 40-year-old is got to be left main or multivessel or bad or nothing normal and stunning. And this is stunning, you know.
So what do you think of diagnosis in this patient? Is it myocarditis?
No. Let me explain to you. And I had a lot of discussion about this. So this is, we hide under the term COVID-19 cardiomyopathy. COVID-19 cardiomyopathy could be simply perimyocarditis or COVID-19 cardiac stunning with the huge immune stimulation. And we know the immune stimulation, you don't see much of a troponin. So if this patient's troponin is small, say 1 or 2 or 3, then the degree of LV dysfunction doesn't match with the troponin load, right? Troponin area under the curve. So it is more likely stunning. We call it simply perimyocarditis if the troponin comes 50,000 or 50 in the new, in the old assay, and new assay is 50,000. So that substantial amount of troponin has to be myocarditis or frank infarct. But a small troponin, I don't know your troponin in this patient. If it is small, then it's more likely COVID-19 related myocardial stunning.
So, but we did a COVID test. I don't know whether that was hospital acquired or he had initially, because our hospital is full of COVID. So can it be the patient had this COVID positive after 6 days because he acquired from hospital?
You can, but with the chest X-ray, we have already documented. That chest X-ray cannot be explained by the, we now know. I mean, for the juniors, if you take a picture of that and go to Google image, the Iranians have done this. By CT only, they have diagnosed COVID. That is COVID until proven otherwise.
Yeah, this is very bad.
Yeah, this is not heart failure.
Yes.
Okay.
If only myocarditis, it should be global hypokinesis of the LV. But here is the regional wall motion abnormality of the LV.
So, I mean, this is well known. Raymond Kim on the MRI showed this nicely. Even myocarditis can give you patchy involvement, regional valve. Here, if you look at the echo carefully, one thing I want you to know, Dr. Maskey, what is the troponin level?
We did not measure quantitative, we said positive only. So, I mean, it's not too helpful. We do not do quantitative.
Any CPK-MB or anything?
We don't do CPK-MB, we just do troponin and said positive.
Dr. Maskey, your first sample negative, second sample or third sample positive?
Which one? COVID? COVID was, we did a second day of admission, it was negative. On 6th day, it turned out to be positive.
But one was an antigen test, right?
No, at emergency, we did antigen test just to take him to cath lab, it was negative. The next day we did, I mean, it's not of use, but just for screening. Second day we did COVID test, it was negative. On 6th day, it turned out to be positive.
Okay. It may be that it was in the 30-40% false negative group.
There could be.
And in antigen also, it is near about 10 to 20% false negative.
The PCR is fairly good. Did you have COVID before last year or 6 months ago?
This patient never had any COVID.
Okay.
And no vaccine?
No vaccine. No vaccine, I think.
Anyway, in this particular case, regarding this scenario, we should consider it is a COVID until and understood otherwise, but it is confirmed by second way by doing RT-PCR COVID positive. So it is COVID, no doubt. But now question is whether it is ACS or myocarditis or perimyocarditis or whatever you like to say.
Yeah, agree. And how is he doing now? Is the hypoxia getting any better or no?
No, he was extubated. We transferred that patient to another general hospital because he had a bad chest. So better to be treated by, because my hospital is only cardiac hospital.
Yeah.
So
maybe a good thing to follow up and see how.
Yeah, we will follow that patients. Okay.
And then in a follow-up echo, because actually if they survive, many of these stunning patients, they actually improve. And then if it is a myocarditis.
Sir, is it type 1 MI or type 2 MI here? All this scenario considering.
So question is, we can't tell until we have a troponin assay. So if it is stunning, then immune mechanism and injury, then it is not type 1 MI for sure. Now, we had this bahas with Azam that if it is hypoxia related troponin, then it is type 2. If it is hypoxia related. But I tell you, if the LV is this bad and the troponin is small, then it's probably immune mediated stunning. In that case, it's not MI at all. But time will tell. Time will tell with the natural history. The stunning patients, they have a better prognosis.
Okay, thank you. I'll just go to next.
Excellent case.
Dr. Maskey's case very nice. He is fast.
Can I go to second case and we'll have discussion?
Yes, Namaste.
So this is another interesting case. This lady came to me to show an ECG. So I'll be happy to get opinion from our learned colleagues. She's a 33-year-old lady. She's a health personnel. She had a Covishield injections. She complained of fever, myalgia, fatigue after first dose of injections. This was her baseline ECG in October 2020. And this is a EKG 18 hours after Covishield. And this is 6 months after Covishield. And this is 7 months after Covishield. There's no LVB, but there's T-wave inversion in V1 to V6. Did an echo in this patient, but no wall motion abnormality. And just for academic interest, did CT just to rule out, because women, they have a spontaneous coronary artery dissections and other things. So the CT is normal. So Covishield vaccine induced LVB has not been reported so far, but there are reports of myocarditis and pericarditis after vaccination for COVID-19. So what could be the cause of transient LVB in this young lady?
Maskey, can you show the ECG again, please?
First of all, Dr. Maskey, this is a done deal for a
this is this is October 2020.
You got a publication already.
And this is after 18 hours after Covishield injections. And this persisted for 6 months. And then after 7 months, this is a EKG. Which would be a good journal, Hafiz bhai? We are planning to publish this one.
Yeah, we'll have to, even you can say JAMA, you can try JAMA case. But I tell you, I'm relieved. Coronary is good, LV function normal. This is all Rafique bhai.
Well, I think my guess would be as good. I mean, we know that this can happen, and if affects the bundle, which improves. But the puzzling thing is that T-wave change in the late the question. I mean, if it has happened that the left bundle disappeared the day before, and I'm doing an EKG after next day or same day, then I can explain this T wave change. But after a period of time, that T wave change should have resolved. So
whatever it is, Dr. Maskey, I need your EKGs because we are doing a book with Dr. Narula, and I will have a chapter on EKGs in COVID time. So
Okay, sure.
may I have these 2 EKGs?
Yeah, sure.
Great collection.
Yeah.
Sir, Maskey sir, is there any recurrent chest pain has got?
No. The patient has no chest pain because she is a health personnel, works in hospital. After COVID vaccination, she had fever, myalgia. She got admitted and then did EKG in this patient. And then she came to me, said, I have this change, what to do.
You did so many things. Did you do any markers? CRP, D-dimer?
D-dimer, CRP are all negative, I think. Because
if you have, Dr. Maskey, if you have MRI with LG, gadolinium, late gadolinium enhancement, I'd like to see, if it's possible.
Well, it's too costly.
Maskey, troponin leakage, troponin,
No, troponin and everything is normal. She actually came after 3-4 months just to take an opinion saying, see, this is my ECG before, this is after. And so can you give me an opinion? And otherwise she's totally after this LVBC is not symptomatic. And she was admitted for a couple of days in hospital. She improved, recovered. And for academic interest, we are just following patients doing EKG in this patient.
I read one article in Yahoo News that Pfizer vaccine did similar type of myocarditis.
No, myocarditis and pericarditis are documented.
Yeah.
But this, I have quoted one.
I wanted to tell everyone this on this opportunity, although there is this hoo-ha about myocarditis and all that, but just for myocarditis, without stunning and failure, the death rate is 0. So there should not be any panic with this. Yes. Because when it is hard, people get panic and then do propaganda against the vaccine. But we need to be careful as a healthcare professional that this myocarditis, pericarditis business, even in the young, has not translated into any death so far, I know.
Yes. And what the media did for that DIC in this by the vaccines, propaganda all over the world and had negative impact on COVID vaccination.
Okay, so can I go to another short cases?
Sure.
Yes. Yeah. This is a 56 years. Yeah, 56 years old male, atypical chest pain, and he had ECG normal, done CT coronary angiogram 4 months back. It reported normal course and anatomy of coronary artery and calcium was 0. This was a ECG 4 months back, and this was a CT saying the left and right systems are quite normal. And this time we presented last week, 10 days back with acute inferior wall MI, posterior extension, and there was also RV infarctions. So this was.
And I'm getting chest pain.
Yeah, this is a EKG upside. This is angiogram. Right is normal. Sorry, left is normal. Right has occlusion of RCA. Did primary PCI to RCA. So my take-home message would be CT angiogram. Yeah, there's high negative predictive values, but it does not show any plaque erosion rupture, which is a cause of infarction. So we should not always rely on CT angiogram just because it's normal. It depends on how do you interpret, how do they make a cuts. So this is one, I think, is a learning point for all of us.
Is there any history
one
of
question?
drug abuse?
No, one question I have, Dr. Maskey, his coronary calcium score is 0, right?
Yes.
That's kind of a little bit positive thing in one sense, because there's possibility because he's young, he probably did not develop calcified plaque yet. This initial phase of plaque formation that might not be calcified. That's why calcium score could be lower. yeah, that doesn't exclude that he's not building up some plaque. And that might not have shown up on the CT scan.
My message is just do not rely totally on CT just because it's normal.
I have one question, please. I have one question. Whether the patient is drug abuse?
No.
Patient having any drug abuse?
No, it's not drug abuse.
So one thing.
Whether it could be a thromboembolic.
That's another, but did you see any thrombus there when you suction it out?
No, I mean, we don't do thrombosuction. It's not recommended. So I just passed the wire, dilated the balloons and put a stents. I mean, of course, there's a thrombotic occlusion. It's 100% occlusion, so acute infarction. So
can I add something? That if the calcium score is low, especially there's no calcium and there is soft plaque, these are more vulnerable for rupture and causing acute MI.
True.
So CT angiogram will not give this feature.
Yes, true.
That's what the calcium.
This is
Can I clarify a few things, if I may? One is that the calcium score, when we acquired the calcium score, it is non-contrast and it just picks up the calcium and then we call it the Agatston score and then define calcium score 0 or 100 or 500. It has nothing to do with the coronary anatomy and stenosis. If we do, that's why when we report calcium score, we say cannot comment on coronary anatomy or lesion or plaque. In your patient, I want to know whether it was just calcium score or it was CT angio was done.
No, CT that was CT angio.
And I saw that, but did they look at the right coronary?
Yes, they do look at it.
Now, after this STEMI, did you go back and see whether there is any soft plaque? Because
no, I went with to the radiologist and discussed with them. I said, something is here. Is that something which is you all missed? Yeah, this is the point.
Yes.
So
maybe this was the point, irregularity. Yeah. Maybe they reported that. I went and discussed with them.
No, there is a soft plaque there. If you look at the lumen, so this is the whole Glackov's hypothesis of arterial remodeling and plaque in the arterial wall. So this patient by any means is not negative coronary disease. He has evidence of plaque there. So, and then another comment is, if there is a emboli that can happen in the coronaries, and the term in the case of STEMI that aspiration, it is not that aspiration is not recommended. Routine aspiration is not recommended. That means you cannot use routinely aspiration or thrombectomy. But when there is thrombus burden, for example, in COVID time, for example, in stent thrombosis, then we do use extraction catheter.
I have a question, Hafiz bhai, to you. If we get this type of non-occlusive soft plaque in the CT angiogram, should we start the secondary prophylaxis with aspirin and statin?
I'm glad that you're saying I would call it secondary prophylaxis, but because there is no event, technically it is primary, and the LDL goal is less than 50, maybe less than 70 for sure.
Okay, thank you.
But can I make a comment?
Yes, sir.
So the patient is a patient who is at risk for coronary disease, and I have to believe the coronary CT angiogram. But I think the learning point from this case is, if that patient comes with chest pain, don't ignore it. It can be unstable angina, it can be acute MI. Look at the ECG. ECG, of course, is very clear. What happens if this is my friend and I can tell you, oh, by the way, you have normal CT angio, you're not having an MI. We should not do that. If the patient comes to the ER, we should evaluate the patient for acute event. That this is a perfect example of a case. I mean, we
very
are
well said, Rafique.
Yes.
But also we need to look at the risk. What was the patient's LDL, diabetic or not? Was the LDL before the MI was good?
Yeah, with normal cholesterol, no diabetes.
I mean the number
non-smoker, no risk factors.
And I think one thing that I'd like to make sure, one point I'd like to make, that whoever interpreted the CT angiogram, that's not normal. I totally agree with Dr. Hafiz. There is some disease there, and we know that less than 50% blockage are the most common cause of heart attack, MI. So we don't need to forget that. So we need to definitely, in the beginning, we need to start all the prophylaxis possible. All right, including statin, aspirin, and behavioral modification, and diet and exercise.
Okay, can I go to one last case? This is also very interesting.
Okay,
this is a last case. 46 years old male diabetic patient on oral medications. He was COVID positive, discharged 3 weeks back, and now COVID negative. He used to visit, because he's a relative of one of the doctor working with me, he used to come to emergency and saying I have some saturation around 90, some chest pain. So once he came with a atypical chest pain. This was a ECG in emergency. And since this patient was frequently visiting emergency with the chest pain, saturation was around 90, and we are observing this patient, and suddenly he developed severe chest pain. So, and what we can see here is the T waves in V2, V3, and some V4 is raised. So that his symptom was typical with the chest pain, sweating. So we decided to take him to the cath lab and see what we can see is up-to-date proximal LAD.
This is a D Winters. The EKG changed like a D Winters.
And so learning is look for the symptoms. STT changes may occur late. Hyperactive T waves are first manifestation, so don't ignore that. And another thing we have noticed is post-COVID era, we have found a lot of patients after COVID. They're coming to emergency with STEMI. So
Arun, can you go back to the second ECG, please? If this patient was not having chest pain, are you going to think much about this ECG?
We'll just observe this patient.
Yes. So this is Arun, these are fantastic cases that you presented, because I think, look at this ECG. If you gave me this ECG and telling that this is somebody who is walking around, I would probably do nothing about it. But the clinical scenario of the patient, and then you compare with the old ECG, that becomes so important. Thank you.
Sir, the important thing, if you look at the EKG, the EKG that before and after, so this is like a classic D Winters type evolution. They look at the angle and the change of the EKG. I absolutely agree. If this is the EKG without any chest pain in the office as a routine insurance purposes, we pay no attention. But the evolution of the EKG from the baseline to this acute angle, this is classic D Winters indicative of prox LAD.
Sir, can I make a comment?
Yep.
This is very important, because what these ECG are showing, that we have to pay much more attention to what the patient is saying, the history. Again and again, we are coming back to that basic point. The history, the context in which that particular ECG is manifested. That's important. Today, I have seen a patient who came with, I was surprised because he had chest pain, typical chest pain, had been to a cardiologist who had done the echo, the ECG, and said, no, you are quite all right. Take some medicine, that will do. But he was having class 3 angina, but ECG is throughout normal. 31st July, the ECG was normal. Today, I did the ECG, I found he already had an MI, antiseptal MI. That physician should have been more attentive to his symptoms. The patient is having symptoms, despite getting medicine, we should go for a little bit more aggressive testing. This is what normal ECG, typical chest pain, we should pay attention, look at the ECG, very subtle changes, we should pick up our ear. We should be careful about that.
Thank you. Arun, do you have anything else?
No, thank you. I don't have anything.
So if you, can you give me 2 minutes?
Yeah, yes, sir.
Yes, sir.
I'm sure.
Sir.
I'm going to share, because this is relevant to Jamil's talk. So I'm going to, if Anur unshare, I will start sharing a screen.
I'm unshared.
It's great cases
Thank you.
you presented. Thank you.
Thank you.
Thank you, sir.
রফিক স্যার শেয়ার করতে করতে আমি একটা কথা বলে ফেলি অদূর স্যার।
বলো,
ওই যে
বলো,
আমার একটা রোগী আজকে আমাদের যে পানি সম্পদ মন্ত্রী আমাকে পাঠিয়েছিল যে ইসিজি নরমাল, ইটিটি হচ্ছে আপনার ইকুইভোকাল, কোন রকমই আমি পজিটিভ বলতে পারছি না, তো অ্যানজিওগ্রামের জন্য পাঠাচ্ছিল। তা আমি করলাম, করে দেখে যে তার ট্রিপল ভেসেল ডিজিজ, ভেরি আগলি ডিজিজ। কিন্তু তার সিম্পটম ছিল, তার চেস্ট পেইন সিম্পটমটা ছিল।
So I put this ECG. This patient came to us in 2019, just routine ECG done. This is the ECG. And I put 3 choices.
Sir, will I go for the poll?
Please, if you
Sir,
can.
for 30 seconds.
Yes.
Okay.
Yeah. So it was at that time, whoever saw the patient, did the EKG, it was reported as sinus rhythm with incomplete right bundle branch block. 2 years later, a few days ago, this patient comes to the hospital with chest pain, and this is the ECG.
রফিক ভাই ইনফিরিয়র এস্টেমি কল করে নাই তো না?
Well, this is interesting. Patient was having chest pain.
That's the point.
Sir, should I start the poll again?
Yes, please.
Yes.
Okay.
Presentation is important.
Yes. So majority actually did great. So this is interesting because what happened, the patient was taken to the cath lab, of course, and the patient had a large posterolateral which was occluded and stented. I think what happened, if we go back to the older ECG, this patient, totally asymptomatic at subtle pre-excitation, you can see in lead V5, V4, V5, V6, even though the PR was not too bad. And then when he presents with acute inferior MI, he develops AV conduction problem, and the pre-excitation becomes very manifest. So after stenting, patient never had palpitation. So the question was what to do. My concern was, has the patient developed complete heart block, that it was conducting only through the, I sent the patient for EP study. And during the EP study, we always induce VF to see how fast it conducts. This conducted at a rate of literally 500 beats per minute, and the patient went into VF. So this is an example of a case which never had any symptom, had subtle pre-excitation, very fast conducting accessory pathway, and patient could have been killed if he had gone into AFib at an outset setting and developed VF. So, I mean, it's not that all of them will do it, but we need to keep that in mind. And this is exactly the same ECG that Jamil showed. So I thought that you'll find interesting. Thank you.
This MI helped him. This MI helped him.
It did. But Hafiz, look at this acute ST elevation, and it can, as you said, that it could be a WPW syndrome. But again, the clinical scenario is what was driving the decision making.
Yes. And look at the QRS widening and the deep QA. So this this may be a little bit late presentation of the MI.
Oh no, Hafiz, after pre-excitation, he did not have a Q wave. This was because of the delta wave. If you look at
this again goes with the traditional teaching. Then don't read the Q wave with the pre-excitation.
Exactly.
Here, all that matters is the ST elevation.
Exactly. Thank you.
So
Thank you
I want to add one comment, sir. Sir, in our clinical practice in third year medicine, we just want to, when I was register, just I want to tell my students, 80% can diagnose by history, 9% can be diagnosed by physical examination, 9% can be diagnosed by investigation, 1% can be diagnosed by trial, by drug therapy, and 1% after death by autopsy or other like that. So the message is that the history is the main path to direct you how to manage your patients. This is my comment, sir.
Thanks.
So Hafiz bhai, can you send me email so I can send that ECG and we can interact?
Yeah, I actually texted Atahar bhai to give me your email.
Okay.
Sure.
I'll send. Okay, I'll send it.
This was a fascinating article.
Today we actually had very beautiful ECGs and very interactive discussion. And I've always preferred this sort of a little bit informal, but very lively interaction. Arun, you have shown very good, very beautiful cases. And Jamil bhai, thank you again for showing us those cases.
You're welcome.
Wadud, I have a comment that I get worried when we talk and we do this adda. I sometimes get afraid that the attendees maybe get frustrated or disinterested. But today, thanks to Jamil bhai and Dr. Arun Maskey, still number of attendees 73. So we did not lose much. So that was because of you. And I congratulate the attendees. We actually feel good if you are there and you are benefiting from it.
Yeah.
Thank you.
And these are actually practical cases, and we all of us are putting in a little bit of tidbits, clinical acumen and everything from our experiences. And that I do think will help the youngsters. Thank you, everybody.
Thank you, sir.
Comment about future classes and other things.
So excellent discussion, and it is very, very academic ECGs today. I like to congratulate Jamil, Arun Maskey, and finally Rafique sir. So today's we want to conclude the today's session. Our next session, next Saturday, our presenter is Rafique sir. Dr. Rafique Ahmed sir will present the next Sunday, sir.
I'll do it combined with Hafiz.
Okay, sir. No problem, sir.
Thank you.
Sir, I like to request you, Hafiz bhai and Wadud bhai, just to stay 2 to 3 minutes more, just after concluding the session.
Okay.
So,
thank you, sir. Good night, sir.
Thank you very much for joining, and
thank you, everybody.
Thank you.
Thank you, everybody.
Thank you. Assalamu alaikum. Good night.
Assalamu alaikum, sir.
Assalamu alaikum, everybody. Assalamu alaikum.
হাফিজ ভাই, আমি এক মিনিট আপনার সঙ্গে একটা কথা বলতে চাই। আপনি একজন পেশেন্ট আমার আন্ডারে ভর্তি ছিলেন।
ও কে?
আপনার মানে